Which of the following statements regarding radiation exposure from CT scans in the setting of blunt abdominal trauma is false? A. A single CT scan may increase the lifetime risk of cancer. B. CT scans are never indicated in pregnancy, given the risk of radiation to the fetus. C. Institutions should follow as low as reasonably achievable principles to mitigate radiation exposure. D. Medical radiation may be responsible for 0.4 to 1% of all cancers in the United States. E. Patients transferred to another facility should have attempts made to convey the images to the receiving facility as long as it does not negatively impact the patient's care. Answer is B. CT scans are never indicated in pregnancy, given the risk of radiation to the fetus. Although there is a risk to the fetus with radiation, there may be situations where the risk of missed injury or exploratory laparotomy outweighs the risk of radiation to both mother and fetus. Patients being transferred to another facility should have attempts made to provide CT scans either in hard copy or digitally to minimize repeat radiation exposure to the patient. Current estimates suggest at least 0.4% of all cancers in the United States are secondary to medical radiation, and a single CT scan may increase the lifetime risk of cancer. Facilities can minimize this risk by adopting as low as reasonably achievable (ALARA) principles. A 27-year-old male presents 4 hours after an isolated stab wound to the anterior abdomen. His vital signs are heart rate 84 beats per minute and blood pressure 115/64, and the lactate level is 0.9 milligrams per deciliter. His focused assessment with sonography in trauma examination is negative for free fluid. He denies alcohol and drug use and appears clinically sober. Which of the following statements regarding this patient's subsequent management is true? A. A diagnostic peritoneal lavage with 250,000 red blood cells per cubic millimeter indicates the need for admission and serial abdominal examinations. B. A local wound exploration that fails to demonstrate peritoneal violation means that the patient can be discharged from the emergency department. C. A negative computed tomography scan rules out the need for further evaluation. D. The negative fast examination rules out intraabdominal injury requiring operative intervention. E. The patient meets criteria for emergent laparotomy. Answer. B. A local wound exploration that fails to demonstrate peritoneal violation means that the patient can be discharged from the emergency department. Simple anterior abdominal stab wounds that do not violate the peritoneum can be discharged from the ED after appropriate wound care. A 67-year-old female who is taking warfarin, Coumadin, for atrial fibrillation presents after a high-mechanism motor vehicle collision. Her heart rate is 142 beats per minute and blood pressure is 84/40 after 1 liter of normal saline. Her Glasgow Coma score is 6, and her left pupil is 6 mm versus 3 mm on the right. Her physical examination is notable for a seat belt sign on the abdomen. Which of the following is not an acceptable approach to her initial assessment and treatment? A. Perform a focused assessment with sonography in trauma examination to evaluate for the presence of intra-abdominal fluid. B. Perform chest and pelvic radiographs in the resuscitation bay. C. Perform empirical craniotomy concurrently with laparotomy in the operating room after a positive diagnostic peritoneal aspiration. D. Perform endotracheal intubation and begin mild hyperventilation. E. Proceed to radiology for an emergent abdominal CT scan. Answer is E. Proceed to radiology for an emergent abdominal CT scan. The patient is hemodynamically unstable, with suspected intra-abdominal injuries in conjunction with signs of herniation. CT scanning of the abdomen would be inappropriate in this patient. Several concurrent management options to stabilize the patient and determine the source of her hypotension are desirable. Endotracheal intubation allows airway control and possible hyperventilation to delay impending herniation. Chest and pelvic radiographs rule out other sources of ongoing hemorrhage and may support emergent laparotomy. A fast examination can confirm the presence of intra-abdominal free fluid, which in the setting of hemodynamic instability is an indication for laparotomy. Finally, after confirmation of intra-abdominal blood by either digital pulse analyzers or fast, proceeding to the operating room, with or without emergent CT scanning of the head, are management options. If the head CT is foregone because of instability, empirical craniotomy is an acceptable management option. Which of the following statements regarding splenic injuries in blunt abdominal trauma is false? A CT scan with a grade 4 splenic laceration indicates the need for laparotomy. B. Angiographic embolization may preserve some of the immune function of the spleen, even in the setting of a grade 5 laceration. C. Bedside-focused assessment with sonography in trauma, although sensitive for intra-abdominal fluid, is a relatively poor test for the evaluation of solid organ injury. D. CT scanning followed by serial abdominal examinations and hematocrits is a reasonable management option at experienced centers. E. Mononucleosis increases the risk of splenic laceration from seemingly minor blunt abdominal trauma. Answer is A. A CT scan with a grade 4 splenic laceration indicates the need for laparotomy. High-grade splenic lacerations, although having a higher rate of failed non-operative or angiographic embolization management, do not represent a definitive indication for laparotomy. Mononucleosis does increase the risk of splenic laceration. Trauma can be so minor that the patient may have little recollection of the remote trauma responsible. Serial abdominal examinations, laboratory tests, and/or repeat fast examinations are reasonable management options at experienced centers. Limited studies have suggested that angiographic embolization does preserve some of the immune function of the spleen compared with splenectomy. The fast examination does not visualize solid organ injury effectively enough to eliminate the need for further evaluation with CT scanning in this case, especially because laparotomy is not necessarily indicated.